Hello everyone, welcome back. Let's start with the CVS physiology today. So in CVS, we'll proceed in this manner. First, we'll start with the JVP, then we'll move on to the cardiac cycle part and the relevant graphs, which are, which I feel very much important. And many of the students will lose marks in the graphs. So I don't want you to do that. So we'll do all the graphs, all the pressure volume loops, all the pulse tracings in detail. And then about the blood vessels and BP regulation, very, very important. Okay, some miscellaneous stuff. So this is all we'll cover in CVS physiology. Rest of the topics will be dealt in pathology and medicine. Let's start with the JVP now. See, what is JVP? JVP is a measure of right atrial pressure, number one. So it is a measure of right atrial pressure. Now, what is the normal value of JVP? Normal value should be less than 4 centimeter. So what is the centimeter? So since it is a pressure, why are we measuring in centimeter? Because this is the height, the vertical distance that we are measuring from the sternal angle. Okay, so the vertical distance, that is what is used to measure JVP. So if you put this jugular venous pulse on a pulse tracings on a graph, so we'll measure 3 ascents and 3 descents. So what are the ascents? A, C, V are the ascents. Then we have 2 descents. So earlier they thought only 2 descents, X and X dash, but they also had Y. So they cannot, keep X dash, X dash. So they named it as Y. So there are 3 descents now. Okay, X, X dash, and Y. So in one cardiac cycle, you will get the tracings. Okay, so 3 ascents and 3 descents. So if you want it to be in a sequence, you remember the rule A, C, X, V, Y. Okay, so you have noticed I have written only one X. So you should understand. So between C, A and C, there is one X, and between C and Y, there is X dash. Okay. This is commonly written to denote the order in which JVP, jugular venous pulse waves occur. Okay, so this is the order ACXVY. Very important, which jugular vein are we talking about? So whose venous pressure did we just measure from the sternal angle? And that is, yes, very good, internal jugular vein. It's not external, it's internal jugular vein. So to understand the JVP, and this is very important, most of the students will find it confusing, but you will not. Okay, so I'll tell you the simple rule. If the blood comes in the vein, then we will have an upstroke, we'll have an ascent thing. Okay, if the blood from the atria comes into the vein, if the blood flows back into the vein, then we will have an upstroke. Okay, and if the blood does not flow back, or if the blood empties into the atria from the vein, then we will have a downward stroke. Okay, so if blood comes down, there is a downward, that is descent. If the blood goes up into the vein, then we will have an ascent. Okay, so this is the basic rule. Now, keeping this basic rule in mind, let's understand the reason behind each wave. So we have the first wave as A wave. Now, why A wave occur? You remember in the last, part of the diastole, atrial diastole, atrial systole will occur. Okay, the systole, the atria will contract. So earlier atria was a little bit larger in size. Now after contraction, it became smaller. Okay, so the main goal of atrial systole was to push blood into the atrium ventricle. Okay, so the goal was to push the blood in the ventricle, but a little part of the blood will still flows back into the jugular vein because no valves is there. Okay, so in upward may no valves are there, but in downward the blood has to wait for the tricuspid valve to open, and that's why first you will see some a wave, some pulse, some upward stroke, and that upward stroke is because of atrial contraction. And since it is because of atrial contraction, it is named as A wave. Okay, so atrial contraction, A wave. Now, after contraction, what happens? After contraction, the atria will relax. So, after contraction, number one, first tricuspid valve will open and the atria will relax. So, atria will get bigger in size and tricuspid valve will open. This will allow the blood to flow back. Okay, so this is what you notice. The downward flow is because of this X downward flow will lead to X descent. Okay, so we are following the rules. The upward slope 8A was because of atrial contraction, and the downward slope is because of this atrial relaxation. So X descent, first X descent is what is noticed because of this. Now to summarize, atria has contracted and that will create A wave, atria relaxation. The relaxation will create X descent first. Then what happens? Then after relaxation, the tricuspid valve which was open, now it closes. Okay, tricuspid valve closes because ventricle is beginning the systole, so that's why the tricuspid valve close, and this closure will lead to a some amount of blood, some amount of blood, a mild backward flow into the jugular vein, and this will create only some ascent. Okay, and that is C wave. So what is C wave? C wave, why it happens? Because of C for closure. Okay, so closure of tricuspid valve. So C wave is because of closure of tricuspid valve. Now, simultaneously, the ventricle systole has occurred and all the blood in the ventricle has been pumped out into the pulmonary aorta on the right side and aorta on the left side. And that is why heart does not have blood now. And this is the time of filling of blood. So, maximum amounts of blood will come, okay, from the jugular vein. The blood starts to come. And in which direction? Downward direction. So, what should happen? Again, a descent should happen. And this is the descent that you see, X dash, okay. So this is the descent, this is the maximum descent because this is the filling wala phase. Very important how much passively the filling occurs. 80% of the blood flows passively from atria to ventricle, okay. So now let's understand this. So this is the baseline that we started with, okay. So this is the baseline. So now what happens? So from here, the passively the blood is filling and this descent has happened. And now what happens? So after passive filling, there comes a point where, the atria doesn't have any space. And whatever the amount of blood that is coming, it will flow backwards. So slowly, it will start, creating this ascent. And that V wave is created, which indicates maximum filling has occurred. Maximum atrial filling has occurred. This V wave. Now let's pause for a second and let's understand. I'm trying only the right side of the heart, the right atrium and the right ventricle. And between them, we have this tricuspid valve. Tricuspid valve, okay? So let's draw the three cusps. So we have this tricuspid valve. Now, after maximum filling of the right atrium, what happens? All this blood will push the tricuspid valve and will open the tricuspid valve to go into the right ventricle. And this is why, the blood is flowing down. So the blood is flowing down and this will create the Y descent. So if we put it in short, the Y descent is because of atrial emptying, okay? YING. So this is because of atrial emptying of the atria into the ventricle. And which atria? Right atrium, that is we are talking about. So right atrium will empty into the right ventricle. This is what is this descent is created. So okay, everybody understood this. Nobody should make mistake. Nobody should tell me they made blunders in JVP. Okay, so there are three ascents and three descents. I'll summarize again. So A was because of atrial contraction and then relaxation. After contraction, relaxation will happen. So this descent, X descent, first X descent is created, and after relaxation there comes a point where closure of tricuspid valve will occur because the ventricles are beginning to contract, and that's why after that they contract a lot. So if we put ECG also here, so you can see, so in this ECG the QRS wave corresponds to the ventricular systole, and that ventricular systole is what is this part. So ventricular systole, after systole nothing will be there in the heart, and the blood will fill the heart. So this passive filling, the 80% of the filling will happen. That is why this is a steep curve. Okay, filling of the atria will happen until there is no space left and there is a positive pressure of the blood is being created. That is what you see in this ascent, V wala ascent. V for venous filling, you can remember, because of this V for venous wala filling. Then all this filling of the blood will be in the right atrium and that will push down the tricuspid valve and that will open, and the blood will flow into the right ventricle. And that is that descent, that Y descent is what is being created because of emptying. Okay, YING, it is emptying. So if they ask you pure diastole wale waves, we have VY waves. If they ask you systole wale waves, this is the ACX VY. So VY is pure diastole ke waves, then ACX is pure systole ke waves. So this is the one type of question that they ask. The next type of question would be the abnormalities of these waves. In physiology, this is the normal thing that we study, but let's cover all the aspects of JVP here itself, even the medicine ke aspects. So I'll repeat this again. So we have a simple schematic diagram which shows internal jugular vein attached to the right atrium and then the right ventricle. Then the outflow of the right ventricle is the pulmonary artery. Okay, so only the right side of the heart is being shown here. For just to make it very simple, so between the right atrium and right ventricle, we have this tricuspid valve. Okay, so this is tricuspid valve. Now let's understand one by one. What are the abnormalities of A wave? So let's understand A wave. So A wave, everybody remember now? So why A wave, the small a? Why A wave has occurred? So A wave was because of atrial contraction, right? A wave, atrial contraction. So when the contraction will be increased, when the contraction will be decreased or absent, Last but not the least, when the contractions will be irregular. Okay, so because contractions, any contraction can be any of these things. So if contractions are increased, meaning what, the atria is doing a lot of work to contract to pump the blood out. And why? There is a damage, or there might be some traffic ahead. So the traffic could be in the tricuspid valve, that is because of tricuspid stenosis. The traffic could be in the right ventricle. Okay, right ventricle has become hypertrophied. So we see this in hypertrophic cardiomyopathy. Or the traffic could be in the pulmonary artery. The pulmonary artery might have become narrow, or the lumen might have become narrow. What is that known as? Pulmonary hypertension. Okay, so the increased A wave could be due to these three things. Number one, tricuspid stenosis. Then we have hypertrophic obstructive cardiomyopathy, or the obstruction could be in the pulmonary artery, and that is known as pulmonary hypertension. Very simple. Everybody followed this. Now let's understand a situation in which A wave will be absent. So what is A wave? A wave was atrial contraction. So now add one more layer to it. So A wave represent coordinated atrial contraction. So if absence of A wave, if A waves are absent, it doesn't mean atrial contraction is not happening. It just means atria is not contracting coordinatedly. So when does this situation arise? This situation is seen in something known as a fib. So in AFib, atria is contracting a lot, okay, because the generated impulses in AFib will be somewhere in between 300 to 600 per minute. And that is why there is a lot of uncoordinated atrial contraction. And so instead of this coordinated wala A wave, you see a lot of fibrillatory waves. And that fibrillatory F wave is seen in AFib. So you can remember, so mnemonic is very simple. So in AFib, there is no A, only F, fibrillatory waves are seen. So this was A wave absence. Now coming to the situation where A waves are irregular. Now what was the normal regularity? The normal regular rhythm was first atria will contract and then the ventricle will contract, the right ventricle. This was normal regularity. If this is broken, and this is said in something known as complete heart block, and they say complete heart block. In complete heart block, what happens? Atria and ventricles, they beat independently of each other. So what does this mean? So ideally, when atria contract, the tricuspid valve must open. And but what happens? Atria is contracting simultaneously. Ventricle is also contracting. So tricuspid atria will try to open the tricuspid valve, but ventricle contraction will push the tricuspid valve upward, meaning it will close the tricuspid valve. Meaning what? So atria might contract against the tricuspid ventricle. The tricuspid valve closed the tricuspid valve, and that is why you see something known as intermittently giant canon waves. So the giant A waves, canon waves is what is seen in complete heart block. So these are the three abnormalities. So everybody understood. No, you no need to remember this. Just understand the concept. So why this is happening? Why? Okay. Now let's understand X descent. So why X descent was happening? Because of atrial relaxation. So if X descent is absent, so what does it mean? If X descent is absent, then atria is not relaxing. Can I say that? Okay, so when will atria relax? So this right atrium, we have a blood in the right atrium. So right atrium was contracting, creating a wave to push the blood to give all the blood to the right ventricle, so that there should not be any blood. Okay, so when will atria relax? If there are no blood in it, if there is no blood in it, when will mother relax? The mother will relax when the children go to school, right? When the whole, she will get some free time, so she will relax. Similarly, the atria will relax when there is no blood in the atria. Okay, so that is why X descent. If X descent is absent, meaning if X descent is absent, why it could be absent? If the blood comes back to the atria again. So this is seen in cases of tricuspid regurgitation. So children, mother was sending children to school, but the children is returning immediately to home. So that is what. So in tricuspid regurgitation, what happens? The atria will contract, it will contract and will push the blood into the right ventricle. But what happens immediately because of this regurgitation? Regurgitation means valve will not function. So immediately the blood will come back. So that is why there is no X descent in tricuspid regurgitation. Let's understand what else is happening in tricuspid regurgitation. See, so this was a normal JVP. So what did we say in constrictive pericarditis? There is no X descent, meaning this line and this line will not be seen. Okay, so there is no X descent. So what happens here? This C and V wave, say, because there is no X descent, so they will merge together, creating something known as large CV waves. Okay, so this large CV waves is what is seen in tricuspid regurgitation. And why? Because backflow. Okay, so backflow of the blood from right ventricle to the right atrium, creating this large CV waves. So this blood from the right ventricle to right atrium, this will not allow the right atrium to relax and keep the right atrium in a contracted state. And since right atrium is a contracted state, you have this prominent C and V waves. So such condition also seen in something known as constrictive though. So the contracted, it will not allow constrictive pericarditis. So in constrictive pericarditis, it will not allow the right atrium to expand properly. Okay, so last CV waves question tricuspid regurgitation and constrictive pericarditis. So you followed, everybody followed. Any doubts? While we are studying about this V wave, the V wave was because of venous filling, right? So remember, V wave correspond to your radial pulse because the contraction were happening. That is why V wave will appear just after the contraction, after the systolic phase, and radial pulse will also appear after the systolic phase. And this is what is known as Modely sign, Moodley, Modely sign. So radial pulse corresponds to V wave of JVP. It's not the A wave. And this is very, very important because it will help you distinguish the JVP waves from the carotid artery pulsations. Okay, so very important. In the neck, you also have carotid artery, so you should not miss it. So that is why V wave of JVP corresponds with the radial pulse. This is Modely sign. Now let's understand the last wave abnormality, that is Y descent ki problem. So remember, Y descent क्यों हो रहा था? It was because of atria emptying into the ventricle. So suddenly the tricuspid valve opened. Remember that diagram? Suddenly the tricuspid valve opened and atria was emptying into the ventricle. So now imagine if the right ventricle, the wall of the right ventricle already contains some blood. Okay, so that blood. So can more blood enter here? No, it cannot. And what is that condition known as, where the right ventricle wall has the blood? And that condition is, my friend, cardiac tamponade. So Y descent is absent in cardiac tamponade. Okay, so Y descent is absent in cardiac tamponade. So you can remember this. Okay, very important. It will be absent, or some people also use the word blunted. Okay, so absent or blunted. So just see this. So this was Y descent. So this was Y descent. If this is absent or blunted, then what will happen? The X will be more prominent automatically. Okay, so these are the two descents. If one is absent, then that other one will be more prominent automatically. So you don't need to remember कि prominent X रहेगा. Just remember the concept ki atria is emptying into the ventricle, atria emptying into the ventricle. Now if that emptying, the filling of the ventricle doesn't happen, then Y descent will not happen, and that is same of the atria already, the ventricle already contains the blood. This is cardiac tamponade. Okay, everyone, stop now. Stop it. Okay. I'll explain in detail again. See, this is constrictive pericarditis. So what are you all noticing here? This is right atrium and this is the right ventricle. So everybody know right ventricle is the front facing part of the heart. Okay, so this is the right ventricle. In this diagram, you also notice that there is inflammation of the pericardium. Okay, so that is known as pericarditis, and this is a figure which represents constrictive pericarditis. And on the other hand, you have this figure which represents there is a buildup of fluid around the heart, and that fluid could be anything, could be pericardial effusion, or the if it is filled with blood, that is tamponade. Okay, so let's understand what happens to Y wave, Y descent. What happens to Y descent in each of this? So we already studied in cardiac tamponade. In tamponade, what will happen? There will be no Y descent or blunted Y descent. Okay, so Y descent will be absent or blunted. So if you want to see how a blunted Y descent looks, so here we have this. So this is how a blunted Y descent looks. So actually it should go like this, but now there is no descent, so it has become blunted. So this blunted Y descent is what is visible in cardiac tamponade. Now, what happens in constrictive pericarditis? In constrictive pericarditis, as you can see, there is some space in the right ventricle. So as soon as the tricuspid valve opens, okay, atria will start to empty rapidly. So there is a rapid Y descent is what you notice, but it will stop in the middle. Okay, it may not completely empty because the wall is thickened by this constrictive pericarditis, and that is why you will see something known as rapid Y descent. Okay, so don't confuse this. So rapid Y descent, this is known as Frederick sign. This is visible in CP, constrictive pericarditis. Okay, let's also cover the relevant points related to constrictive pericarditis and cardiac tamponade here itself. So number one, What is constrictive pericarditis? Here there is thick fibrotic pericardium. Okay, number one. So that thick fibrotic will be non-compliant. It will not stretch. Okay, it will not stretch. So stretching is the problem here. So this is constrictive pericarditis. Stretching is the problem. So initially there will be rapid flow, rapid diastolic filling. Early diastolic filling will happen, but late diastole may it has to stretch, and that stretching will not happen. So if stretching does not happen, what happens? There will be backflow. So there will be backflow of the blood, and that will raise the JVP, and that is what is commonly known as Kussmaul sign. Okay, so Kussmaul sign. What do you understand by the term Kussmaul sign? Kussmaul sign means normally what should happen? The JVP should fall during inspiration. Okay, that is the rule. But what happens? In constrictive pericarditis, due to this backflow, which is backflow, JVP will rise. This is Kussmaul sign. So in constrictive pericarditis, early filling will be normal, early diastolic filling will be normal, but late will be an issue. Okay, late may it will not stretch, it will be non-compliant. Due to the early filling, you will also notice in the heart sound as pericardial knock in the early diastole. Okay, so pericardial knock is the typical heart sound that you notice here in the early diastole, in the early diastole here. And in the JVP, you will notice all the rapid descents, and this could be an either M pattern or W pattern. So whatever you call it or however you look at it, it is MW pattern of JVP. If they ask, this is classical for constrictive pericarditis. Now moving on to cardiac tamponade, what are the typical features? Before moving on to that, can anybody tell me why constrictive pericarditis will happen? What are the main candidates for this? The etiological factors, remember, whether there is fibrosis, so TB, or any post-surgery or post-radiation. Okay, so this could be a reason for classical causes of pericarditis, that to constrictive pericarditis. Now let's understand what is happening in tamponade. So in tamponade, see a lot of fluid or the blood, whatever you say, so it is being accumulated in the pericardial sac. A lot of fluid is there, and this is right ventricle and this is left ventricle. So this will constrict both of them. But since we are talking about JVP, so we said the right ventricle is constricted, and that is why it cannot fill. Okay, so atrial emptying cannot happen. So Y descent will be absent. So with respect to JVP, we told since Y is absent, so what will be more prominent? So X descent will be more prominent. Okay, so no need to remember. If you want to remember, there is a mnemonic, that is tax is the mnemonic. So in tamponade, X will be more prominent. Okay, so that is the mnemonic for this. But if you want to, let's just complete the other important points of cardiac tamponade. So cardiac tamponade, first of all, why it is seen? It can be seen in cases of trauma. Okay, so number one, trauma. So in trauma, what you will notice? So if you auscultate that patient, you will notice this muffled heart sounds. Okay, so muffled heart sounds is typical of cardiac tamponade, number one. Number two, the absence of Y descent and prominent X descent, that is with respect to GVP. And if you're talking about this, so how can you ignore the fact that it is also constricting the left ventricle? So if left ventricle is constricted, what happens? The systolic blood pressure will drop significantly. That is, what is that known as? What is the typical one that you study in medicine? Pulsus paradoxus. So normally the systolic blood pressure SBP during inspiration will fall. How much normally it should fall? Normally it should fall by 2 to 5 mm of Hg. Okay, so that is a normal fall. Normally it should fall 2 to 5 mm. But in cases like tamponade, it will fall exaggerated. The fall is exaggerated. How much? By more than 10 mm it will fall. So this is what is known as pulsus paradoxus. The exaggerated fall on SBP due to this pericardial constraint because of tamponade, it is also seen in lung pathologies like severe asthma. So that will make that exaggerated fall of SBP by more than 10 mm mercury, that will give rise to pulsus paradoxus. So in short, if you want to remember, just remember the basic thing here. In the cardiac tamponade, the problem will be throughout the diastole. Okay, so throughout the diastole, filling problem will be there. Diastole throughout the diastole. But in constrictive pericarditis, in early में तो fill हो जाएगा, early में ये fill हो जाएगा, but in the late part where it has to stretch, it will not stretch. So late diastole में problem है. Okay, so that is a rapid Y descent Frederick sign is same. How do we treat this condition? पेरिकार्डियोसेंटेसिस किसको करेंगे आप? जहाँ पे फ्लूइड है, सो यू ट्रीट दिस बाय पेरिकार्डियोसेंटेसिस. यू ट्रीट द कार्डियक tamponade by removing that fluid. पेरिकार्डिएक्टमी किसको करेंगे आप you will do for this constrictive pericarditis. Okay, so I hope you have understood JVP in detail, and this is what helps you crack every question related to JVP. Okay, see you after the break. Bye bye.